Good afternoon and welcome. I'm William Wolf. I'm a psychiatrist on faculty at the VA, and on behalf of the selection committee, I am delighted to welcome you to the 2021 Robert S. Wallerstein, MD, Visiting Lectureship in Psychoanalysis and Psychotherapy. A few words of thanks from the committee to begin. Of course, first of all, thanks to the Wallerstein family and the supporters of the lectureship for making this event possible. Thanks to the UCSF Department of Psychiatry and Behavioral Sciences, which has been a home for this lectureship from the beginning. A special thanks to the residency training program, which has made it possible for residents to attend every year, and it's so important, especially as it's harder every year to give them exposure to analytic thought. And to a home within, which has provided sponsorship for our continuing education credits. And you'll hear more about opportunity to volunteer with them at the end of the lectureship. And finally, to Gina Martinez, who's guided and supported this event from the very beginning and has found a way for us to continue this in this format. We're on Zoom. Zoom is hard. We learned that over the past year. You know, if you could be in here, you'd see that there are 4 people in this huge auditorium, but that's how we're working it. We're also going to keep it brief. Our speaker has had a lot of experience with this format, and we've really tried to make it something that can be enriching and within the levels of tolerance that we have for Zoom after a year of this. So I'll be brief. First, a quick reminder about Bob Wallerstein. As you know, he was the chair of this department from 1975 to 1985. And he was ahead of his time. I've talked about this in past introductions. But relevant to today's talk, he was the person who started the first infant mental health program in the state of California. It was right here at UCSF, San Francisco General Hospital. He recruited Selma Freiberg to run the institution, and she recruited our speaker. And it was only a year after her death, or I should say it was a year after she arrived, that our speaker arrived, that Dr. Freiberg passed away. And since then, our speaker has sort of risen to becoming a real powerhouse in this field, not only at UCSF, but internationally. So we're so fortunate today, not only to have a speaker of such stature here, but someone who can speak personally about the impact that Bob had on her thinking and her career. And I know that she really reflected on it even as she was preparing for this talk. So it's a real honor to introduce Dr. Alicia Lieberman. She's the Irving B. Harris Endowed Chair in Infant Mental Health. She's professor and vice chair for faculty development at the UCSF Department of Psychiatry and Behavioral Sciences. She is director of the Child Trauma Research Program at Zuckerberg San Francisco General Hospital. And she directs the Early Trauma Treatment Network, which is a center of SAMHSA National Child Traumatic Stress Network. She developed child-parent psychotherapy, which is a treatment for traumatized children up to the age of 5 that's been widely disseminated. And it has its origins in Freiberg's work. And I think we all know she's the author of The Emotional Life of the Toddler, which is a hugely influential book, now 28 years after it was first introduced. She's received countless awards. If I listed them here, it would take most of our Zoom time. So let me just say it's my great honor to welcome our 2021 keynote speaker, Dr. Alicia Lieberman.
Thank you so much, William. You made me feel like we're in a real lecture hall. Thank you very much. And I also want to thank, of course, the Wallerstein Committee, echo the thanks that William gave before, and thank the Wallerstein Committee for inviting me to give this lecture. And to thank the Wallerstein family, who has been sending me lovely emails in advance of today, including an early morning email from Amy Wallerstein Friedman saying that the Wallerstein family is watching this lecture from different parts of the world, and this is one of the silver linings of doing this on Zoom. Still, I miss very much those warm, rich afternoons where we spent the lectureship together here at Cole Hall. And in the spirit of the season, I want to say next year at Cole Hall again. This is a very meaningful lecture for me because, as William said, Bob Wallerstein is the reason that I am at UCSF. And I want to start my talk with a brief history of how that happened and to give you a sense of Bob's lasting influence through his commitment to a community-minded psychiatry. In the 1970s, the field of infant mental health was just emerging, but with his customary vision, Bob anticipated how crucial this field would become to understand child, adolescent, and adult psychopathology. In 1979, he invited one of its pioneers, Selma Freiberg, to relocate from the University of Michigan to create the UCSF Infant Parent Program, IPP, at San Francisco General Hospital, which, as William said, was the first infant mental health program in California, and at the time was one of just a handful in the entire country. Selma had been my postdoctoral mentor, and through her, I found my vocation. So I was thrilled when she asked me to come here from NIMH and help her meet specifically the needs of the large Spanish-speaking community in the Bay Area, many of whom were refugees from the genocidal wars in Central America. Bob and Selma had a marvelous intellectual and personal synergy that gave early impetus to my career. It is worth noting that together they put their ideals of equity, inclusion, and diversity into practice decades before this goal was adopted by academic institutions. With their leadership, IPP brought two-generation psychoanalytic psychotherapy that was gold standard and culturally responsive to poor and disenfranchised babies and their families, most of whom were from underrepresented minority groups and were bearing the brunt of historical trauma perpetuated in the present through racism and marginalization. IPP gave the parents hope. Our treatment helped them overcome their anger and despair and give their babies the loving care that everyone in the family deserved. And IPP continues to do that to this day. Bob's legendary advocacy of collaboration across disciplines was well represented at IPP. Selma was a social worker way before she was a psychoanalyst. And our beloved Graham Hanson was the program psychiatrist, and social workers, psychologists, and our one psychiatrist together made IPP into a sterling clinical and training program, many of whose graduates became and remain leaders in public health and started other important programs, including the BICHO Early Intervention Services. Through this leadership, there is now a California Association of Infant Mental Health, or CALAIM, that is a member of the World Association of Infant Mental Health, WAIM. California has national stature in infant mental health, and Bob and Selma set us in this trajectory. Bob remained an enthusiastic champion of community psychotherapy even after Selma's premature death in 1981. And I am personally grateful to him for his lifelong support of my career, including his warm encouragement to write The Emotional Life of the Toddler, and his strong encouragement to start the Child Trauma Research Program in 1996 in response to a request by Bob Oken, the then Chief of Psychiatry at the General. For all the reasons I described, there is a very special synchronicity in the timing of this lecture, which coincides this year with IPP's 40th anniversary and with the 25th anniversary of the Child Trauma Research Program. It is the right time to give thanks for the ongoing vitality of Bob's legacy. The title of my talk starts with Internalizing Reality. I will first outline in broad strokes some aspects of external reality, of inner life, and of their convergence for young children and their caregivers. I will then describe child-parent psychotherapy as a two-generation treatment that helps restore external safety, security in the child-parent relationship, and renewed capacity to love as the outcomes of repairing trauma. I will end by showing how the principles of trauma repair can be generalized from our clinical playrooms to systems of care and become part and parcel of our collective pursuit of social justice for children and families. Bob's message that we need a psychoanalytic understanding of reality is one of the huge contributions of his work. I want to linger on this slide for a moment so that you can read it and appreciate the passion and eloquence of his writing. Please note his playful example of a 3-year-old asking, "Where does the outside go at night?" which Bob equated with, "What is the reality of the night? What happens to everything I saw during the day?" Bob, at a time in the 70s, at a time of great social turmoil, not unlike our times, wrote, "There are now many outsides, antithetic in various degrees to one another, and each laying claim to our allegiance. And we're no longer so sure which of these are indeed outside and which inside, or how one tells which is which. And on top of all this, we're no longer so sure of the moral." Bob deconstructed and challenged psychoanalytic concepts that we took for granted, but that ignored the specificity of multiple realities. He questioned Hartman's concept of the average expectable environment, dismantling its basic presumption that we can rely on a predictable, generalized environment that is comparable for most people, and that merely serves as the backdrop for the individual's psychic trajectory. A lot of research now supports both positions. The hugely influential Adverse Childhood Experiences, or ACEs study, shows that even in a middle-class population of primarily white Kaiser Permanente patients, there is a high prevalence of very specific types of adversity, many of which overlap and compound each other with long-term health consequences. In this sample of about 18,000 respondents, almost 2/3 reported at least one type, not one instance, but one type of adverse, potentially traumatic childhood event, and more than 25% endorsed 3 or more types of these events, including child abuse, child neglect, domestic violence, and growing up with an adult with a mental illness or an impairing drug or alcohol use. Bob's insistence that we must examine the infinite variability and frequent mutual incompatibilities in the different dimensions of reality is particularly prescient in the present moment, when social inequities along racial and ethnic lines that we have long overlooked are now starkly visible in the differential impact of COVID-19 on Black, Indigenous, and people of color, on working class people, and on people living in poverty. COVID-19 is not the same storm for everybody, and not everybody has the same kind of boat. Many people who were functioning well enough, to paraphrase Winnicott, are often breaking down in very individual ways under very specific kinds of pressures, as shown in the steep increases in crime, including hate crimes, domestic violence, drug overdoses, and psychiatric conditions. As Bob knew, we can fail our patients if we assume from their appearance or social class that they grew up and continue to live in an average expectable environment, because trauma and adversity happen regardless of one's social privilege or socioeconomic circumstances, although of course the most marginalized are also the most affected. The impact on the environment in shaping who we become is nowhere more apparent than in the first 5 years of life, which are the most vulnerable to accidental injury and child abuse. It is challenging to raise young children, and even more so when parents and children do not have the supports that they need. Poverty is itself a risk because it means more food insufficiency, instability of housing, dangerous neighborhoods, and daily hassles that all compounded predict higher risk of domestic violence and child abuse and neglect. More children are hurt or die from child abuse in the first year of life and in the first 5 years of life than at any other age. And children aged birth to 5 account for a disproportionate percentage of children placed in foster home and never returned to their families. These early traumas are in turn associated with changes in brain structure and physiology that affect emotional regulation, attention, and learning, because even babies are biologically primed to respond to environmental threat with the basic survival responses of flight, fight, or freeze, which are useful in the short term, but constrict loving and learning, which are the two basic building blocks of mental health when they become chronic. The good news is that improving environmental conditions improve the odds of healthy development because we're basically a resilient species and respond well to good conditions. For example, increasing income for Native American families with 9-year-old children significantly reduced the children's later drug use. In a study with Native American families in the Great Smoky Mountain study in North Carolina, when the group with a higher income was compared with a group of comparable families that did not get the benefits of increased income. And I was very happy to read this morning in the San Francisco Chronicle that Oakland is going to be instituting a program of monthly income for families in poverty living in Oakland. In our work, we find many examples of improvement as a result of improved conditions. For example, children's cognitive performance improved significantly after treatment when their family conditions became safer and their attachments became more secure. And this positive impact of a good environment is why it is crucial to support young children and their families, both as an end in itself and as an investment on who young children will become for themselves and for society when they grow up. As the ACE study showed, and many others that followed confirmed, there is such a high prevalence of adversity and trauma in the general population that it is best practice to routinely screen for exposure to past and present traumatic events in all the patients we see, regardless of their social circumstances. This also applies to young children because, as we saw, they are most vulnerable to abuse and neglect. This 2010 study by Cindy Crasto at Yale University was the first to demonstrate empirically that if clinicians don't ask, parents often don't tell. But when clinicians do ask specific questions, parents are very often accurate reporters, willing reporters of child trauma. And in this study, I just want to highlight that before children were screened in a community mental health program, 43% of them were diagnosed as having behavioral, social, or emotional problems, and only 13% were diagnosed as showing traumatic stress symptoms. And then Cindy Crasto asked permission from the clinic to administer to the families the TESI, the Traumatic Event Stress Inventory, which Chandra Ghosh Ipen in our program and Julian Ford at the University of Connecticut created as part of their work at the National Child Traumatic Stress Network. And after the parents were asked specifically about traumatic exposure for their children, it turned out that 48% of them had experienced 5 or more traumatic events, and 39% had PTSD symptoms, which means that all this time that the children had been in treatment, they had been treated for the wrong condition. The American Academy of Child and Adolescent Psychiatry recommended in 2010 routine trauma screening as a way of ensuring accurate diagnosis and appropriate treatment, including preventing misdiagnoses such as ADHD or bipolar disorder instead of PTSD, due to the similarity of symptoms between these different psychiatric diagnoses. Widespread implementation of the AACAP recommendation is still a work in progress, but we need to take this advice seriously because it makes a real difference in ensuring that children receive the treatment that they need. Now, I hope that I made a persuasive case for why external reality, what happens to children and families, matters. And now I want to turn to the rich inner life of young children. In his 1926 article, Inhibitions, Symptoms, and Anxiety, Freud outlined these 4 internal dangers that Brenner truly insightfully later labeled the 4 calamities: fear of loss, fear of losing love, fear of body damage, which Freud called castration anxiety, but we know that it is a much more generalized fear than only castration, and what he called fear of superego condemnation, which I like to rephrase in a more user-friendly manner as fear that there is something deeply wrong with us and that we cannot live up to our own ideals or to the standards of society. Each of these anxieties emerges in steady developmental fashion between ages 1 and 5, building on each other and becoming our lifelong companions, bubbling up whenever internal or external conditions threaten our sense of safety. Children experience them even when their parents are remarkably attuned and responsive. And parents re-experience them even when their life conditions are consistently safe and supportive. There is no escaping them. But we can usually reassure ourselves that these fears are in our imagination and will not become true. When acute stress and trauma occur, however, particularly in the form of family violence, young children learn the indelible lesson that these fears are real, that they will be left or hurt, that they are unloved, and that it is all their fault because they've been bad. This is the inner-outer boundary, where the inner world and the perception of external realities reinforce each other. This slide helps us think about how external reality and typical anxieties converge. We all experience a continuum of stresses in our lives that make us feel anxious. And these stresses range from normative and expectable challenges like the birth of a sibling for a young child, or balancing one's budget, or calibrating one's intimate partner relationship for an adult, through more costly stresses like medical conditions, serious and persistent financial insecurity, or chronic family conflict. Traumatic stress is at a whole different level because traumatic events happen suddenly and are overwhelmingly powerful. So they don't give us time to prepare for self-protection. In CTRP, my program, we use the conservative DSM-5 definition of trauma as exposure to actual or threatened death, serious injury, or sexual violence, either directly, witnessing, learning that these events occur to a family member or a friend, or being repeatedly exposed to aversive details of these events, like with first responders, for example. Freud defined the traumatic moment as confronting us with our terrifying helplessness. When we are flooded by intense stimuli that signal danger and that they are too big and immediate to overcome. In the aftermath of trauma, once we've survived trauma, we can no longer take safety for granted. It has been said that accurate reality testing is the first casualty of trauma exposure, because even moderate and expectable stress can trigger a reminder of the traumatic moment. Everyday stimuli are no longer neutral. A car engine that misfires can trigger a panic attack in the survivor of a mass shooting or in a war veteran. Were many instances of young children whose performance in cognitive tests, for example, collapsed in response to a question that they did not expect. For example, what is a knife used for? For a traumatized 4-year-old who saw a knife used to attack, the question can trigger an intrusive image of the attack that for the moment erases the knowledge of its more usual use as a kitchen utensil. We witness dissociation and resorting to baby talk, to babbling in just such a 4-year-old. If we did not know that a knife was a trauma trigger, we would think that this child did not know what a knife was. Our understanding of our patients can change radically when we learn the specifics of what happened to them, and the effort to understand the origin and meaning of traumatic triggers is a central component of trauma-informed psychotherapy, which should be all psychotherapy. Now, trauma often changes the quality of the relationship between young children and parents. And this happens most often when the child has a parent who is also traumatized. This can be because young children and parents are often together, so that, for example, a car accident affects both of them individually and together, or the parent witnesses the child's accidental injury in a way that shakes the parent to the core. Most of the time, parents remain protective, and children use their basic trust in the parent to restore feelings of safety. For example, a 3-year-old girl who nearly drowned and became unconscious after falling into the swimming pool during her birthday party asked when she became conscious again, "Where is my cake?" We can imagine her reliving her loving family celebration of her while she was working her way back to consciousness. Another child, a 4-year-old boy, said to his father, "Not all dogs bite," when the father tried to move his son away from an approaching dog a couple of weeks after the child was bitten by a dog that he tried to pet in the park. However, in more frightening and less supportive conditions, the traumatic event can trigger negative changes in the child-parent relationship. A one-year-old girl that I will call Elsa persistently turned her face away and refused to be held by her mother after a stranger attacked them on the street, overturning the stroller, injuring the mother on the face, and leading to a separation that lasted several hours while the mother received medical care. We can imagine this child's recoiling and avoiding the mother as meaning in part because she could not speak. "You hurt me. You left me. Who are you? You don't look the same. Will you hurt me and leave me again?" The mother in turn was deeply hurt by what she perceived as the child's rejection, which compounded the damage to her sense of physical and emotional integrity following the attack. The mom asked, "Will Elsa ever love me again?" Here again, there was a healthy momentum towards relatively quick repair, but both the mother and the child needed help. The clinician said to the mother, "Elsa gets really worried when she sees that your face is hurt. You look different to her. She doesn't know that your face will heal. And it makes her remember how scared she was when you were attacked and you went away, and she did not know if you would ever come back." Giving this benevolent meaning to Elsa's behavior was very reassuring to the mother, who was able to join the therapist in a game where they used toys to reenact the attack, making a red mark with crayon on the mother doll's cheek to show the injury and then erasing it several times in a row to show healing and joyful reunion. The child's symptoms decreased significantly in a few weeks. The example of Elsa and her mother shows us that maladaptive defenses to fend off the experience of threat can emerge in the first year of life, even as early as 3 months. This is not new. It has been observed for decades. This slide shows a list of defenses that my team and I and many of our colleagues have assembled to demonstrate defenses in the first years of life. And Selma has a marvelous article about defenses of early childhood. What we're seeing in a new light is how very young children internalize and enact violent relationship patterns and often alternate quickly from moments of identification with the aggressor to moments of feeling victimized. I will give you the example of 4-year-old Roger, who put his legs akimbo and pretended to hold a gun and pointed it to his mother and said in a menacing voice, "Don't make me have to shoot you, Mommy." Roger had witnessed many scenes of his father's violence against his mother. And after his father left, he was now taking on the role of aggressor. Roger also beat his nails to the quick and woke up crying during the night when his defenses were down and his fear emerged, crying, "No, no, no." His inner world was in turmoil. He simultaneously loved, feared, and missed his father. He loved his mother, hated her for failing to protect him and for making his father go away, and feared that she would leave him, just as she had left his father. His mother was not aware of the confusion of feelings that Roger experienced. She only saw him as an exact replica of his father, whom she had left to protect herself and her son. She focused not on Roger's nightly fears or beaten nails, but rather on his aggression. And in moments of anger, she said to him, "You are just like your father," reinforcing Roger's fear that she would leave him as well. This takes us to the question of what happens to a young child's overwhelming fear of being left, unloved, hurt, and being bad. Left unaddressed, it is fair to hypothesize that Roger's fears might in time become repressed, and his self-protective anger and identification with the aggressor would be consolidated as his prevailing character structure. If this happened when he became a father, Roger might relate to his own baby as a transference object, experiencing the crying baby as an unbearable reminder of his own unresolved pain, and possibly hurting or even leaving his child in a repetition of the past in the present. Selma Freiberg called this reenactment "ghosts in the nursery," and her genius involved helping the parents reconnect affectively with their early fear, redirecting their anger from the present baby to its proper targets in the parent's past. In this process, using Selma's language, the parents release the baby from engulfment in their projections so that they could now perceive the baby's crying as a signal of need rather than an accusation, and they could respond with care rather than with anger or avoidance. The next question is, how can we help the present-day Rogers of all genders in the here and now, after they have been traumatized, when we see these maladaptive defenses already taking root in how they respond, but before these defenses become chronic, rigid, consolidated? We want to ensure that the nurseries that one day will harbor their children do not become populated with the ghosts from the past. My late friend and colleague, Patricia Van Horn, and I made that question the organizing core of our work when we developed child-parent psychotherapy, extending Selma's work to treat present-day child trauma in the first 5 years of life. We established partnerships with primary care clinics, child care centers, domestic violence shelters, child protective services, and the judicial system. And we received referrals of babies, toddlers, and preschoolers enduring traumatic events that we never thought we'd see or hear. The challenge we faced was, how do we treat present trauma in young children who are barely verbal. We encountered enormous pressure from the referring sources, from many of our cherished colleagues, and from the parents themselves to not talk with these young children about these frightening events, because they argued that if we did, we would be re-traumatizing the child. And that is something that none of us wants to do. In this largely uncharted territory, we relied on another champion of reality, John Bowlby, who argued that yielding to the pressure not to speak subjected the children, in his words, to, quote, chronic distrust of other people, inhibition of their curiosity, distrust of their own senses, and a tendency to find everything unreal. We also knew, however, that we could not speak to young children about their trauma without first securing their parents' permission, without first forming a partnership with their parents, who were very often complicit or even the perpetrators in the traumatic events that had happened to the child. We knew that both we and the children needed the parents as allies, both to affirm their children's external reality and inner experience, and to create a new and safer convergence of external and internal reality for them. And so in developing child-parent psychotherapy, we built in a commitment to understand the parents' life experiences and psychological makeup as a prerequisite for a clinical formulation that could help the child. It's taken us years, and it'll continue to take years, but we are confident that our basic premises are solid because we've also seen years of good results, not just in our clinic, but in the places that have adopted CPP as their form of treatment. And the basic components are that we engage the parents as our partners, and then we hold joint child-parent sessions, interspersing them as clinically indicated with individual sessions with the parent, and sometimes even with individual sessions with the child, and moving back and forth, always having more than one lens, moving back and forth between the past and the present, the parent and the child. In creating child-parent psychotherapy, we adopted the motto, speaking the unspeakable, to remind ourselves that acknowledging painful realities when spoken lovingly and supportively and compassionately is healing. We start by meeting primarily alone with the parents for an extended assessment and engagement first phase of treatment, anywhere from 3 to 8 sessions, and sometimes more, that we call the foundational phase, because its goal is to create the building blocks to understand what happened, how is it affecting the family, both for the parents and for the child. When the parents' trauma history, both in the past and the present, distorts their perception of the child, as it did with Roger's mother, this foundational phase involves an abbreviated form of ghosts in the nursery treatment, where the clinician works with the parent towards an understanding of how their own experiences of fear, anger, and pain shape their lives and their current feelings about parenting and about the child. This foundational phase culminates in a feedback session where we guide the parents in planning a treatment approach that includes speaking candidly with the child about what the child saw, heard, and knows, how these events are linked to the difficult behaviors and feelings that the child is showing and that are bringing the child to treatment, and how the parent and the clinician will help make things better. We try to be tactful in speaking the unspeakable, and we try not to overspeak it. We think of it as a haiku, a brief but precise use of child-friendly words about what happened and how it is affecting the child and the parent. We also think of it as a form of guided free association, because once we present this frame, we respect the child's and the parent's pace and timing in exploring these links between events and feelings and behavior. How did we do it with Roger? During the foundational phase, Roger's mother remembered that long before her violent relationship with her husband, she had family relationships where her father, mother, and 2 brothers also hit her. And she came to realize that that is what she expected of relationships. And that when Roger was aggressive, she forgot that Roger was a 4-year-old boy who needed her, who missed his father, and who had learned from him that hitting was how disagreements were settled. She cried over her painful childhood, and she came to realize that Roger was suffering in ways that were like her own suffering as a child. Talking with parents and children about the links between traumatic events and how those events make them feel and behave is what we call presenting the CPP Triangle. And it's based on what the Spanish sociologist José Ortega y Gasset called Yo soy yo y mi circunstancia. I am me and my circumstances. Namely, my identity is part and parcel of my conditions. And when my conditions change, my sense of I and me can also change. In the first joint session with Roger and his mother, the clinician said, "Your mommy told me that your dad is not living with you. She also told me that it was very scary when he used to hit her. Now you sometimes get mad and sad and hit, and you cry at night, and she gets mad and yells at you." This is while Mother, Roger, and clinician were sitting around with toys that involved an ambulance, a doctor's kit, some kitchen utensils, and other toys that are a combination of trauma-related toys and supportive, everyday, growth-promoting toys. Roger listened silently and said very quietly, "And she hits me." This was a surprise because the mother had not mentioned it during what we thought was a very candid, heartfelt, foundational phase. But children are often ahead of their parents and of their clinicians in their urge to speak their truth. The clinician bought herself time from this surprise by repeating, tried and true formula, "And she hit you?" The mother looked flustered and said to Roger, "Only when you hit me first." It was at that moment as if 2 children were heatedly debating who was to blame. The clinician offered an accepting bridge of connection between them, saying, "It's easy to hit when we are angry and scared. Your mommy does not like to hit, and you don't like to hit. This is a place where we can talk and play and practice how not to hit when you are mad, because hitting hurts." In accepting both the child's and the mother's experience, the clinician gave both of them the message that hard truths could be tolerated and the hope that things could get better. We use play as one of the main vehicles for this work, and I like to think of play as the child's royal road to the unconscious. In CPP, the child's play is free, but it is also framed by the initial formulation triangle, which provides guidance and a shared understanding of the child's circumstances and how the child is responding to them. Roger was a magnificent player, as most children are when we let them. In the initial sessions, he did not include his mother in play, but instead took the clinician to jail again and again for her many transgressions, which he recounted in detail while the mother watched uncomfortably from the sidelines. In one session, the mother tried to protect the clinician from going to jail, but Roger stepped out of the play and told her, "You stay out, Mommy. You are bad." The clinician also stepped out of the play, saying, "I think you are still mad at your mom that your dad went away." And in response, Roger's play switched. He now asked the clinician to tie up his wrists and to send him to jail. And it's interesting that the play became quite heated because the clinician did not want to tie Roger's wrists and did not want to send him to jail because she was afraid of becoming a real transference object of a perpetrator. And she said, "But you are only a little boy. I don't want to send you to jail. You can't be bad. Little children don't belong in jail." And Roger said fiercely, "You do it." So the clinician did it. And this happened again and again. What the clinician and the mother did was to build in a protective narrative into the trauma narrative to contain the affect and remember protection by calling loudly for Roger, telling each other that they missed him and wished he were back, and then greeting him joyfully when he made his grand entrance back. In one of those sessions, after a very animated bout of play, Roger breathed deeply and said to the therapist, "I love you, even when I am angry with you." And he looked very thoughtful, as if realizing something very important. And the therapist said, "Thank you, Roger. I think you also love your mommy, even when you are angry with her." And the clinician looked meaningfully at the mother to include her in this message. And the mother, taking a clue from this, said, "I am sorry that Daddy went away, baby. I know you miss him. I miss him too, but he hurt me and he scared you. We can't live together anymore." Roger looked very sad and leaned against her as his mother gently rubbed his back. Through play and through linking play after play was finished to honest, direct dialogue, they could integrate their emotional polarities and create a new and safer intimacy with each other. All effective trauma treatments share some basic principles, and CPP has incorporated them and adopted them. Safety always comes first, including the clinician's safety. Other fundamental content includes identifying traumatic triggers, because this is the starting point to move from reliving the trauma through somatic and affective dysregulation to remembering the trauma in the mind and placing it in the context of a meaningful life that is not defined by the trauma. CPP places a lot of emphasis on helping parents retrieve early memories of feeling safe, protected, and loved. moments that we call angels in the nursery, to contrast them with ghosts in the nursery. These protective angel narratives are an antidote to the emotional weight of trauma narratives and serve as guides for the good moments that parents want to create and recreate for their children and themselves. CPP integrates many different sources of knowledge, including but not limited to child and adult normative typical development and psychopathology, attachment, psychoanalytic concepts, developmental guidance, concrete assistance, and crisis intervention with problems of living, and the guides and regulations of the legal system involving child maltreatment and domestic violence. As a result, CPP is challenging to teach and challenging to learn. In response, we have a systematic training approach that is organized around the 6 treatment fidelity strands that were developed by Chandra Ghosh-Ippen, which involve asking ourselves, 1, reflective practice, am I aware of my own countertransference reactions? 2, emotional process, am I emotionally attuned to the parents and to the child as separate individuals? 3, dyadic relational, am I able to hold in mind the parents and the child's often contradictory developmental agendas and individual needs, and translate these needs for each other in ways that promote empathy and conflict resolution? 4, trauma framework. Do I remember to use a trauma lens to identify possible triggers to dysregulated behavior? 5, procedural. Have I followed the structure of CPP and provided a foundational phase, a feedback session, and a clear clinical formulation triangle? And 6, do I organize my interventions around core content areas of safety, truth, triggers, affect regulation, integration of emotional polarities, meaning-making, reciprocity, problem-solving, care coordination, and hope? As I said, it's not an easy treatment, but neither is psychoanalysis, and it does work, and it is teachable and learnable. To help in the learning, we have also written books that describe our theoretical formulations and intervention guidelines. These guidelines are manualized, but are descriptive rather than prescriptive, because treatment at its best is a highly individualized co-construction of the child, the parents, and the clinician. Too much prescription inhibits creativity, but too little guidance can leave inexperienced clinicians internally disorganized, feeling ineffective and burned out in their vicarious re-experiencing of the family's trauma. Our books try to find a middle way between the two. And I'm happy to report that it works. We have a lot of evidence of CPP effectiveness, with 5 randomized studies in 2 independent programs, our own CTRP and Mount Hope at the University of Rochester, with Dante Cicchetti and Sherry Toth and Jody Mann as lead investigators. This slide is a snapshot that shows the clinical significance and large effect sizes in decreasing PTSD diagnosis, and it stands for dozens of similar graphs showing, for example, stabilization of child cortisol, increases in child security of attachment, increases in IQ, decreases in maternal psychiatric symptoms, and increases in marital satisfaction. And these outcomes last anywhere between 1 and 9 years after the termination of treatment, depending on the length of the follow-up that the research funding allowed. The most recent finding right here at home is the result of our partnership with Nikki Bush in collaboration with Alicia F, Ju Lin, and other UCSF faculty, who found that CPP is associated with a reduction in preschoolers' telomere shortening, which is a biological marker of cellular aging. When these children who were treated with CPP were compared with a matched community sample of children not receiving intervention. Telomeres are basically the protective caps at the end of our DNA, and the length of one's telomeres naturally shorten over time as we age. This shortening can be accelerated after exposure to trauma, leading to greater risk for a range of mental and physical health outcomes like depression and heart disease. These recent findings by Nikki and her colleagues suggest that CPP can not only improve symptoms and relationships in our 5 randomized studies, but can also lead to reversibility of the biological effects of trauma on the children and hopefully decrease the risk for health problems down the line. This map gives you a sense of where CPP has been adopted around the country. Our dissemination team, led by Chandra Ghosh-Ipen and Nan Chu, has created a systematic training and dissemination protocol to meet the national demand. There are now about 2,000 clinicians and 70 trainers around the country rostered in CPP, with many more currently in training. I believe that this demand reflects a growing recognition that we cannot help young children without also caring for their parents and caregivers and for their relationships. And also, hopefully, a growing recognition that core psychoanalytic concepts remain extraordinarily relevant and can be applied successfully in community settings by clinicians from a variety of disciplines. We're now extending the reach of CPP to the perinatal period, because this is a ripe period for maternal and paternal ambivalence, and also an optimal time to join the parents' impetus for emotional growth and their hopes for their babies and themselves. We've been very sobered to see how negative parental attributions can be directed towards the unborn baby, who is perceived as manipulative, deciding to turn around and not allow the mother to sleep precisely when she needs to rest, aggressive, potentially just like his father, etc. Our research findings to date show significant decreases in maternal anxiety, depression, and potential for child abuse after perinatal CPP treatment. And the next step is to conduct randomized studies to reach the next level in rigorous empirical evidence of efficacy. With the leadership of Gloria Castro, we are creating a training protocol that is based on our recently published book and manual, Make Room for Baby, and we are getting ready to launch its national dissemination. And in parallel, Marquita Mays, in our program, has developed a magnificent group intervention for Black pregnant women and men that she calls Embrace, and that she calls a love letter that uses the Black culture as a container of love and support for African American pregnant women and their partners. We believe that the CPP framework and principles have wide usefulness beyond the clinical playroom that extends to system change. To expand this application, our activities include the training of UCSF students through the Child Trauma Center, which is a partnership between the Child Trauma Research Program and the ICAP, Multicultural Clinical Training Program at the General Hospital. We are adapting CPP principles to group formats. We're implementing it in community settings with the leadership of Miriam Dimmler and Vilma Reyes, including implementing it in family resource centers, schools, and agencies that serve highly stressed families. We collaborate with primary care, DPH, Child Protective Services, National Head Start, and other systems nationally. And we are implementing it in other countries, including a group format that was developed by Vilma Reyes and is called Seeds of Attachment, Semillas de Apego, and has been used successfully and is being tested with a randomized study directed by economists at the Universidad de los Andes in Colombia, with families that are refugees from the decades-old civil war in that country. One example of our efforts to be engaged in system change is the UCSF CalQuick initiative, California ACEs Learning and Quality Improvement Collaborative, led by Eddie Machtinger, Anda Kuo, and Margarita Lightfoot, with a grant from the Office of the Surgeon General. This is part of the statewide initiative launched by Nadine Burke-Harris to promote screening for ACEs in primary care of medical child and adult patients in an effort to decrease trauma exposure in this population. The framework CalQuick created in collaboration with Ken Epstein, who brought both his clinical wisdom and his systems wisdom to bear, and is implemented in 50 clinics around the state, is called Triad, and it incorporates the CPP Triangle formulation in a screening protocol that is an intervention in itself, because it involves asking not only about ACEs, but also about distress responses and about sources of strength and support in an open, warm, relational way that enhances patients' trust and physicians' job satisfaction. All of this, of course, could not happen without the support of our funders, private and public. These are long-standing, close, collaborative, very meaningful relationships. And I am very happy for the opportunity to bring these funders to this space and say thank you publicly, as well as my private thanks. And of course, we have many individual donors and champions who bring other donors to us. Thank you. You know who you are. It takes a village to care for children and families, and this is also a great opportunity to thank the CTRP team. We've been together for an average of 10 years, and the fruit of their labor speaks for itself, I hope. They teach me a lot, and I am grateful for their enormous talent and commitment. Work is a pleasure with them. They are my second family. And I also want to thank the families. Disclosing one's most painful secrets takes enormous courage and momentum for growth. Everyone in our team learns every day from the children and families who come to us with the trust that we will be there for them, and they are as much part of the work as we are. I want to close with an appeal to everyone to reach out in every way we can to help vulnerable children and families. The Bay Area has everything that it takes to transform lives and make a better place for all of us. This is the time, and I go back to my tradition to quote the Talmud and say, if not now, then when? Thank you very much.
Wonderful.
We had to try to clap for all of you, but we heard you. Thank you so much for the wonderful talk. Dr. Mark Jacobs is a psychiatrist, psychoanalyst, and clinical professor in the UCSF Department of Psychiatry and Behavioral Sciences. He's the founding chair of this lectureship from the beginning, and he's been a lifelong leader in psychiatric education and psychotherapy training. He was the founding director of residency training at the UCSF Integrated Residency Program, so that's Langley Porter, the VA, and San Francisco General. And you know, we take for granted the richness of that 3-hospital experience for our residents, but it wasn't always so. So he started that and was in that role led that program for 25 years. Like Dr. Lieberman, he has a long list of awards. I'll just mention one, the department's first annual George Sarlo Prize for Excellence in Teaching, which is their highest prize. He currently teaches, provides clinical supervision, and is in private practice in San Francisco. Mark Jacobs.
So Alicia, I guess I want to start by asking you, you've given lectures over decades. I don't know how many, we couldn't even count. You've had discussants over decades. Has a discussant ever said to you, I have nothing to add? No. I will try to add something.
Don't believe you.
Oh, yeah, I have something. All right. Because really, what can I say that could possibly do justice to Alicia's lecture today, a lecture that is based on decades of her research and clinical experience in the areas of attachment, child development, and trauma, and the relationship of those areas to one another, and more specifically, to how those relationships bear on the novel integrative treatment model she has developed for the joint treatment of children and their parents. A model that is situated within a modern psychoanalytic framework with roots dating back to the work of John Bowlby and inspired by Alicia's direct experiences treating infants and mothers around the kitchen table alongside Selma Freiberg, and nurtured by the vision and leadership of Bob Wallerstein, who foresaw the enormous importance of the infant parent program with its novel conceptualization of a dyadic treatment of infants and mothers that grew out of its pioneering research base, which Bob believed could also play an important role in advancing psychoanalytic theories, and in particular, the relationship of those theories to the clinical practice of psychoanalysis. The answer? Do that in one sentence. And it seems a little absurd for me to try and reduce Alicia's lecture to a few takeaways for many reasons, not the least of which is that Alicia is such an articulate and eloquent speaker and writer. Her talks are mesmerizing, and her writing is clear and poetic. Furthermore, Alicia, you cannot be reduced, but I will try a few takeaways. One in the area of attachment and trauma. The model, a lot about related to the model Alicia presented today. The influences of Bob Wallerstein, and a few remarks about and questions about angel memories, which you didn't say so much about, but this will give you an opportunity to. So, as we all have learned through the work of John Bowlby, followed by Selma Freiberg, and now through Alicia's work, that the parent with childhood trauma, whose trauma is unresolved, can bring the ghost of that trauma into her current relationship with her child. And when trauma strikes, and when both parent and child are simultaneously exposed to it, this is what we see. And you gave beautiful examples, so think of Roger and his mother. We see the picture of a mother who is trying to manage her own stress response, which now is joined by the distress of her 0 to 3-year-old, which now reverberates with the ghost of her past childhood experiences of trauma. Likewise, Roger, the child, is trying to manage his stress response with the limited resources of a 0 to 3-year-old, who at the same time has to now deal and include managing the distress of his own mother. Meanwhile, the child with these limited resources, this distressed mother, whom he would normally go to for a problem like this, but now he cannot because she is frightening to him. The fear without solution, that is a famous phrase in attachment literature. Is that Bowlby that said that? Mary Main said that. And so his stress overwhelms and increases because he can't be calmed by his mother. In other words, each member of the dyad, mother and child, is mutually and simultaneously triggering and overwhelming the other in what I will convert to attachment language and call it a perfect resonance of traumatic misattunement. It is also an example of what is meant by the term intergenerational transmission of trauma, and it is exactly for circumstances such as these that CPP and IP, infant parent treatment, before that were developed, which are both dyadic treatments. Alicia has shown us through her research with countless children from diverse ethnic backgrounds, diverse socioeconomic backgrounds. She's shown us this in homes, hospitals, psychiatric clinics, medical clinics, stairwells and basements, that dyadic treatments in general and CPP in particular are the best approach with the best chance of success for restoring the mental health and psychological functioning of the child and the child's parents and family. And dyadic treatments are the best, if not the only treatment that would be effective in situations like this. And if you read more of Alicia's work and Selma's work, you hear those interpersonal interpretations that are, I think, are unique to the dyadic situation and are just incredible, the way they encapsulate the conversation that should go on between the mother and the child, the therapist speaking for the mother and then the child. It's incredible work. And she's demonstrated the effectiveness of her CPP treatment through this research with countless numbers of children from diverse ethnic and socioeconomic backgrounds, which you saw in her slides. She has demonstrated this in houses, hospitals, and clinics, and basements, all around. Alicia has shown us that, and she really began her talk with this, that the scope of trauma in the environment of the child is wide and extensive. Environmental trauma is ubiquitous, whether that trauma comes out of the conditions of poverty or our communities, or from interpersonal strife and relational violence in our families, or from injuries, illnesses, hospitalizations, anywhere. It is this reality that is facing children everywhere, a reality that must be conceptualized and incorporated into our treatments of childhood psychopathology. This is what Alicia is telling us is needed, and this is what Alicia has done by developing CPP. CPP acknowledges the reality of the child's traumatic environment and places the reality at the core of this model. It is part of the therapeutic stance, which Alicia may have a chance to comment on later. And she's developed a training, which she's told you about, used by clinicians all across the country. And what she didn't tell you is she did one yesterday, while getting ready for this talk. Alicia told us that one of the inspirations for addressing the problem of reality came from the work and writings of Bob Wallerstein. So I would now like to add a little bit to that. You talked about the average expectable environment, which was the centerpiece, really. In 1972, Bob was the president of the International Psychoanalytic Association, and one of the roles of the president is, he's the president of the International, is to develop a theme for the year, which is then delivered which is then stated through an address. And Bob chose the topic and the theme, psychoanalytic perspectives on the problem of reality, which he explained was a topic that has been, quote, relatively neglected by psychoanalysis, which means ignored. Bob was the master of nuance and understatement. He justified the importance of this topic by pointing to Freud's structural theory, which we'll just say the ego is managing the influences of the id, the superego, and reality. And so I think Bob's first point was, he didn't say this, on a mathematical basis, reality ought to get at least 1/3 of the attention, right? But his most important points concerned what Alicia already told you about the average expectable environment. And I'm going to elaborate on that point. But I think what Bob was essentially saying is that the reason the problem of reality had been relatively neglected is because it was too complicated, which is not a very good answer for Bob. So he went on to talk about how really complicated it is. And he used an example, and this is back in 1972, 7 years before the infant parent program would arrive at San Francisco General. And one of the first examples he cited was from infant developmental research. And he cited a small finding, which is also a kind of an accidental finding, and it related to babies who were in distress and the mother's lifting the baby, and depending on how the mother lifted the baby, the position of the child, the baby would, if they did it in one way, the baby's eyes would open widely, and they would be soothed more quickly, and there'd be all kinds of visual and vestibular stimulation, which it was posited would have an impact on the growth and development of the infant. And this is what Bob said about it. What is central to my thesis here is that in the array of mothers, are those, many with the time and inclination, for whom such soothing behavior comes naturally, more than it does for others. The point is that the outer reality here, both the maternal reality and the outer visual perceptual reality, can be so crucially different for each child, and by inference, along so many other parameters of normal or natural mothering behaviors as well. Small and at times chance variations in environment can have large developmental and behavioral consequences. So that's the small ones, and Alicia's working with the large ones. Well, let's see, I'll add that one of the key is, you've also talked, in addressing the large ones, the interplay, of course, between the environment, the experience, and, as Bob would say, the therapeutic enterprise, that these relationships between the environment and the individual have to be integrated. There's also a point that he made in the language of ego psychology, so think about adaptation and defenses. And I'll quote from him again, that often all therapeutic efforts are of no avail if the patient is continuously exposed to situations with which he has no other way of coping but his characteristic defenses. That is, situations in which the very defenses, which it is the work of the therapy to weaken and penetrate, are continuously maintained and strengthened by the environment. The variable environmental forces Rappaport calls structure maintaining forces. So in Alicia's work, we might call them structure dissolving forces in the world of trauma, where dissociation is frequently a frequently used defense. Or to put it in parable terms, it's hard to get someone to put down their umbrella while it's still raining. You can't treat, you won't be able to make any progress with the child's traumatic response if the trauma is continuous. You were talking about earlier about Bob's sensitivity to cultural issues of the day and social issues, and he was prescient in this regard. And so I'm going to read one thing from that as well. And it is inherent in my presentation today that it is not just a platitudinous restatement, but rather the affirmation of an important analytic task to face the fact that our customary and ordinary assumption that we can empathically intuit the realities of the ethnically different patient's life is not necessarily so. Put in our critics' lingo, the Black experience in America is a different from reality from that which any analyst has known. He concludes his talk with a very Bob-like message. I think I am aware at this point of the difficulties of the overall undertaking here proposed, than of any successes achieved. But I hope I have at least pointed to the high promise as well as the intrinsic value of the task. Bob was interviewed by Luca Di Donna in 2011, and she asked him about his work with the problems of reality. And this was Bob's response. I wrote a number of papers, but somehow that work, which to me was important, did not get much attention. Till now. If only Bob were here. And Bob, I think, has been here with Alicia and I these past few weeks as we've been reflecting on the talks for today. So I have one question about intergenerational trauma and its transmission. And you've been focusing so much on the environment, on the social interactions or the social impact of the environment on the traumatic experience. And so I wanted to ask you if you think that as opposed to the ghosts that that you mentioned and talked about and that Selma developed, are the representations of interpersonal trauma, are they represented differently? And then are they transmitted in a different way? Or do you see something different in the next generation of trauma, and the next generation of parents and children, in people who are experiencing environmental stressors? Do they represent the experience differently? And if so, are there differences in the way you see that trauma transmitted from one generation to the next? And to think about that. Or not. There may be other questions that are more interesting that come up. A car accident would be an example, so not interpersonal. Does that get transmitted? Is represented differently? Does it get transmitted and have a different kind of impact in the way it's represented? I want to add something about Freud and his contribution to the problem of reality, besides his development of the structural theory of the mind. And this relates more to what he did than what he said. This comes from a 1977 paper by Samuel Lipton, which is very influential for me when I was a resident. And this is a paper, in this paper he refers to Freud's Ratman paper, Notes on the Case of Obsessional Neurosis, which is of Paul Lorenz. And Lipton pointed out that in Freud's judgment, on at least one occasion, it was a necessary part of the treatment to serve Lorenz a meal. Freud said that this had a positive impact on his moods, and probably another time it happened as well, and that Lorenz's fits of agitation would sometimes subside when Freud fed him. I think today we would say that Lorenz was hangry, but I think we could say that Freud's attention to the matter and Alicia's attention to the basic requirements of safety and security, and I would include being fed, are all essential for psychotherapy to take place, and that Freud was demonstrating this in 1907, although not much mention of it is made. So the last part, I wanted to talk and ask about angel memories, which I think you really underplayed this. It's one of the most interesting contributions you've made. And you call them angel memories, and I was thinking of calling them instead internalized somatic representations of the experience of being cared for. It's, I think it's more masculine than angel memories. I don't think you'll change it.
Let's quote them.
Okay. So Alicia's shown how how angel memories can play an important role in the treatment of parents with a history of childhood trauma by creating a positive emotional counterbalance to the pain associated with its evil twin, the ghost memory. She also says that views angel memories as growth-promoting forces, which may derive from whatever role they play, helping to integrate the good and the bad, internalize object relationships. Or the chiaroscuro. Attachment theorists are poets. They use disruption and repair. Everything has a flow. I wouldn't say disruption and repair. I would say broken and fixed. But that's the beauty, I think, of attachment theory is the way they describe real developmental sequences in children and then attach phrases to them that carry so much meaning, kind of like angel memories. So how do we begin to completely conceptualize what these memories are or what they do or where they come from? I don't know. I hope you will say more about it. But I thought about the concept of mentalization. I think you mentioned that. And comparing mentalization and the way it works with angel memories. And mentalization can provide different kinds of information depending on which kind of side that you're talking about, which way in which you're talking about it. So the capacity for mentalization or reflective function can serve as a measure of psychological functioning, right? And the capacity for mentalization can also be developed. So mentalization can be both a marker and an agent. It can be a marker of psychological function and an agent of psychological change. And I'm wondering, is that how you are also conceiving of angel memories? Because you talk about them as being growth-promoting factors. And you also, I think, and this is where I would want some clarification as well, have also talked about their presence as being indicators of a different kind of traumatic response in mothers, and in mothers who have had, let's say, the same amount or the same kinds of trauma. You have found different amounts of angel memories. So when that happens, is that an indicator, a marker of a healthier response, a healthier adaptation? And so that's a question. And you've also talked about using angel memories in treatment. And so, of course, I want to know how you think that works. And maybe you'll have a chance to comment on that. And whether you see this analogy between mentalization and angel memories, at least in that way, as important. And maybe a little bit about how to unearth angel memories or unheaven angel memories. And I'm going to close. So John Bowlby conducted his professional life with passion, courage, and intellectual zeal. He studied patients in their homes, schools, hospitals, clinics, I think, and prisons. In the same vein, Selma Freiberg developed a revolutionary dyadic treatment for traumatized mothers and their infants, and conducted this treatment around a kitchen table in the homes where the patients and the children resided. Bob Wallerstein came from Germany as a boy and intentionally went to Topeka, where he mounted what today is still one of the largest and longest studies of psychoanalytic psychotherapy research, before becoming the chair at UCSF. when and where he brought Selma Freiberg and her amazing team of clinical researchers, clinicians, that included Alicia Lieberman to San Francisco General. And I think that this sequence marks the very first case of the intergenerational transmission of angels, ending with you, Alicia. It is from this lineage that Alicia carries the most important social, cultural, and scientific values, which he has applied to the advances of psychoanalytic theory, attachment theory, clinical research and care, to the people who need it the most. And for all of this, I just say thank you, Alicia.
Thank you. Thank you very much.
I'll let William take over.
Why
don't you go up and I'll sit down.
Okay. Thank you.
So we do have some questions in the chat, but first, if you wanted to respond.
Thank you. You are a deep thinker, Dr. Jacobs. And I am going to be brief. Thank you for pointing out that I underplayed Angels in the Nursery. I think you're right. And I think that what I was trying to do actually through my examples was to show angels being created. I really wanted to have the clinical material speak about the importance of using benevolent memories in the here and now to counterbalance the impact of trauma. And I think that what Roger and his mother did together was creating angel memories that were facilitated by the fact that his mother in the foundational phase could reconnect with the experiences that she had of fear as a little girl. And when we asked her about angel experiences, she remembered her grandmother and shelling peas in the kitchen with her grandmother, and her grandmother humming songs with her and calling her my girl. And the clinician asked, are there memories like that you would like to create with Roger, or that you have with Roger? And she started remembering moments with Roger that had gone underground in the experience of her fear and anger and worry that he would become like his father. So we can sit down and go into a theoretical formulation of mentalization. I personally have always had a bit of a reaction to mentalization because I think it leaves the body out. Mm-hmm. And what we are constantly looking at in work with children and with trauma is the integration of the mind and the body in a way that leaves neither out. And so I'm hoping that that just gives you a capsule answer that we can then elaborate on.
I think you added an important thing by adding, and you've said this, the intention is also a big piece of it.
Yes.
That is part of the therapeutic stance.
Yes.
Is the intention that is conveyed to the parent.
Yes.
We want you to remember more of those.
Yes.
And apply them to your
Yes.
child.
Yes. Thank you.
Thank you.
Thank you. So we do have, if you want to add questions, just click on the Q&A at the bottom of the screen. First question is from Nick Canis. The question is, how does childhood trauma relate dynamically with complex PTSD and with borderline personality disorder?
That's a good question. Bessel van der Kolk talks about complex trauma transcending the regular domains that are encompassed in the diagnosis of PTSD, so that every aspect of the personality is fragmented. The sense of self, the sense of relationships, the sense of a future, the sense of one's productivity and constructiveness as a human being, so that the different domains where our identity is manifested are affected in complex trauma. And he also talks about, and Bob Pinos talks about, the fact that in complex trauma is most likely to occur when there is a violation of protection in relationships in early childhood, and when the violation is perpetrated by an attachment figure. So that it goes back to what you were talking about, Mark, the question of what gets transmitted. And what we find is that what usually gets transmitted is interpersonal trauma. And that how a parent might respond to an external event that is traumatic is what gets remembered and transmitted. In a car accident, was one left, was one dismissed, was one demeaned, or was one protected? And so it's again, when Bob Wallerstein talks about the fact that in the description by Freud of the convergence between external and internal realities, the word convergence gets downplayed. And it's in the convergence of how do my relationships respond to my external circumstances. That's what gets internalized. Yeah, and I think that speaks also to the question, I hope, that was asked about complex trauma and PTSD.
Thank you. The next question is from Margarita Lightfoot. What types of adaptations were necessary to apply CPP to African American and Latinx families?
That is such an important question. And what I'd like to say is that listening deeply, asking ourselves, how can I become knowledgeable as much as I can about the social circumstances, historical experiences, specificity of what happened to cultural groups? And how can I imagine how these current sociological circumstances of what is happening, what is the neighborhood where this person lives? What are the everyday resources and deficits in resources that this cultural group has experienced? Is actually learning as much as we can about a cultural group, African American, Latinx, Asian, etc., taking it as a responsibility that we need to learn about the cultures of the families that we work with, and at the same time being aware that every family internalizes their culture in their own particular way, acknowledging that we belong to a different cultural group and wanting to ask, how does that feel? How can we establish a dialogue? Do I have permission to ask about your culture? What can you tell me about your culture that will help in the treatment so that the acknowledgement of cultural differences becomes an integral component of the intervention?
Thank you. Actually, Farshid asks a related question. So how to address families with ongoing community trauma?
That is why I think I spent a bit of my talk in how important it is to get out of our offices and engage the systems of care that can create new realities for the families that we work with. And the question of actual help with material resources, engagement with family resource centers, engagement with child protective services, engagement with primary care, and trying to change the external reality of families, both for the family that we're working with and for families in general, is part and parcel of it, and is why it takes a village. That's why we need to be doing it all together, because even though creating safety in relationships is an important protective factor that enables the child and the family be stronger in coping with external adversity, it is not enough. And I think that is why the incorporating crisis intervention and concrete assistance with problems of living is an integral component of the work that we do.
Mika Gonzalez asks, how do you think CPP will evolve over the coming years?
It's a good question. I wish I had the vision to tell you. I think that it's all in how we're going to be doing it together. One thing that I can say is that it evolved already in response to COVID, where we needed to move from home visits, from the here and now in our playroom to Zoom. And children and parents have been absolutely marvelous, by and large, in accommodating to those changed circumstances. And one thing that is, some children have given us access to the room, to their pets, to their toys, in ways that we had not been aware of before. Some children use the camera in Zoom to turn it on and off when we are not being particularly tactful, or we need when they need some time off, so that we are learning that leaning into the virtual session can actually uncover aspects of external reality and inner experience that we did not believe were possible before. And so I think that as society changes, CPP, because the question of interpersonal responsiveness is really the key to CPP. As the society changes, CPP will think, how can we respond to these changes and adapt to them?
Ricardo Munoz says, Alicia, the way you continue to adapt and expand the applicability of your work is amazing.
Thank you.
Could you talk to us a bit about case 2 in your latest book, The Mayan Pregnant Woman, and how her dyadic treatment eventually becomes triadic, including the father?
Oh, thank you for reading Make Room for Babies so carefully, Ricardo. This is a case that was treated by our wonderful former CTRP member, but always part of the family, Manuela Diaz. And it is an exquisite demonstration of what Margarita Lightfoot was asking about. How do we get attuned to the specific culture? Margarita, I'll give you examples when we meet about how this happened in this particular family. We are very, very cognizant of the importance of fathers. And in the case of perinatal child-parent psychotherapy, we always start with an invitation for the father to come in. There are times that the pregnant woman says, I need my time alone first to process what is happening to me. And when I'm ready, I'm going to have the father come in. There are other times where the father comes in from the beginning. In the case that that Ricardo is talking about, the coming of the father was once something important had been solved in the mother's internal experience, and the conflict with the partner had become the next step in what needed to be happening to create a safe environment for the baby. And the clinician and the mother agreed together that it was time for the father to come. So it's very much attuned to the rhythm of the psychotherapy. There have been times where the fathers come first, and then they bring the mother, and there are times where what is happening between the mother and the father is so impossible to bridge that we actually meet with the mother and the child and the father and the child separately. But we explain that there will be no confidentiality between the sessions because the child cannot feel divided between the mother and the father. And we explain that the goal is to have the child feel permission from the father to love the mother and from the mother to love the father without feeling that they are endangering the love of either of them.
Amy Love asks, have you done CPP with older children or teenagers and their parents to create new angel memories and heal together? She's thinking about older foster children who were not reunited for many years and trying to mitigate the initial trauma as well as the separation trauma from being removed.
The work that Miriam Dimmler is doing in community agencies is extending to older ages as well. And the most frequent answer that we get in surveys that we make of people who have been rostered in CPP about how are they applying CPP is, and what changes have they made in their application of CPP, is that they are using it with older children as well. And so for us, because we have a commitment to the first 5 years of life as a very underserved part of the age range, we continue to have our core in that age range, but others have really taken it to older ages as well. One thing that I underplayed, and I'm hoping to make up for it now, is that we developed a group intervention called attachment vitamins that Anchu is disseminating nationally. And attachment vitamins is a psychoeducational form of intervention, the subtitle of which is Attachment, Stress, and Trauma. And we essentially meet in parent groups to start the sessions by asking parents, can you talk about a moment of connection with your child, a moment where you really felt last week that you were really connected? And that is a magic port of entry, where parents relax and they start thinking of pleasure, of building angel memories. And then we talk about what children need, about children's temperament, about sources of stress, how stress affects children, and then move our way into trauma and how trauma is actually more frequent than anybody thinks and how it affects the parent and the child. Adolescent parents who receive attachment vitamins ask for a second dose because they get to say, what? You mean what I feel towards my baby is just the way my mom was raising me? Wow, that's cool. And they have a new understanding of themselves at a very important developmental transition for them. And so this is part of why I feel that CPP principles really are applicable beyond the place where we develop them. Thank you for the question.
Thank you. I'm noticing that we crossed over the 3 p.m. line.
Thank you.
And, I wanted to thank you so much for your...
Thank you so much, and thank you for all the questions. I don't know where to look because I don't know where the camera is, but okay. Thank you very much. Thank you very much.
And a reminder about the Home Within, who sponsored our CE credits. It's a network that provides free psychotherapy services to children in the foster system. So if you're interested in participating, I think we will put a link in the chat, or you can Google A Home Within.
Thank you.
Thank you, William.
Bye-bye.